I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. I think the role of clinical trials has rapidly evolved for advanced non-small cell lung cancer in the past 5 years. Many patients, I think, feel like clinical trial is a bad word. It either means that they're at the end of the line and there's no other therapies available, or that they're going to be randomized like a guinea pig to a control arm, which is placebo, in which they receive no therapy. And it couldn't be further from the truth. I think what we've been able to do in the past 5 years is really design novel clinical trials with drugs that are extremely well tolerated, that have biological rationale, and that which there's no real placebo, that everyone gets the drug of interest. And we've come a long way in pushing the envelope with survivals in advanced non-small cell lung cancer. And that's predicated on trial enrollment and testing these new therapies. When I came into the field 15 years ago, there were only 3 drugs in lung cancer. And now we have more than 25. And a lot of that is, again, predicated on these great clinical trials that were designed to ensure the patient got the drugs, and also that these drugs were novel and really well tolerated and had meaningful activity. I mean, a lot of the drugs that are now designed, there's a tremendous amount of work that goes in on the back end. We have a new drug approval, it seems like, in lung cancer every 5 to 6 months, and 2021 is no exception. I would ask all patients to talk to their doctors about clinical trials. Oftentimes, the therapies that's better for my patient is the clinical trial versus standard of care. So when patients walk to my office, no matter what line they are, no matter what mutation they have, oftentimes we'll say, you've gone through standard of care, and now we have a second line trial that I think holds much more promise than any sort of standard of care second line treatment I could give you. And the same rings true for first line. It's not just in the refractory setting. I have a clinical trial right now in which I feel very comfortable giving, a novel therapy that looks very good and ensures everyone gets the drug versus what is the standard currently. So, clinical trials are where we're heading. We need to remember that only 5 to 8% of all lung cancer patients go on clinical trials in the US. And so we have to do better. And we have too many good drugs now that we can leverage that really will translate, I believe, into meaningful outcomes and meaningful improvement in outcomes for our patients that are probably going to outperform the standard. So ask your doctor about them, and talk to your doctor if he doesn't have these trials, where these trials may be, because as many drugs that we've had approved, we have further ones coming down the pike that are very exciting.